Hello everyone, I am Dr. Jigisha Pujara, Professor in Cardiac Anesthesia, UNMICRC Institute of Cardiology and Research Center. Today I am going to speak about assessment of the cardiac masses by transesophageal echocardiography. Echocardiography remains the principal modality for the identification of the intracardiac masses. Due to higher frequency and closer proximity, transesophageal echocardiography provides unparalleled and unobstructed window into the heart and offers a superior evaluation of the most normal and abnormal intracardiac structures. Role of Tee-Cce, better definition of the mass size, shape and mobility as well as the tissue characterization, clarification of the mass, location, attachment, extent and the myocardial involvement. Striking benefits for the evaluation of the masses in the LA appendage, RA and the aorta or in the patients with the technically limited transthoracic images. Dynamic evaluation of the intracardiac mass and associated abnormalities of the valves at the bedside. 3D reconstruction allow dynamic representation of the views simulating intraoperative visualization of the cardiac masses. Intraoperative Tee-Cce cardiac surgery for the intracardiac mass is a class 2 indication for the perioperative Tee-Cce. Once a cardiac mass is confirmed, intraoperative Tee-Cce is useful in guiding the surgical approach for the mass removal. Tee-Cce guides in placement of the surgical cannula in presence of the cardiac masses, whether in the IVC, SVC or the aorta, to assess the hemodynamic effect of the mass, preoperative, postoperative as well. Immediate and real-time assessment of the surgical intervention, residual masses as well as the unintentional sequelae of the mass removal such as the ventricular or the atrial septal defect as well as the valvular and myocardial function prior to leaving the OR. Studies highlighted role of the intraoperative Tee-Cce, detection of the additional pathology, inability to find the thrombus or alter in shape or size of the thrombus due to embolization, alteration of the caval cannulation in case of the right atrial mass and addressing the valve for repair after mass removal. There are so many studies which suggest Tee-Cce is helpful intraoperatively in case of the cardiac mass. Differential diagnosis for the cardiac masses like anatomical variants, implanted devices, thrombus, vegetations, tumors, primary or the metastatics and the artifact. My whole talk will be divided into two, anatomical variants and the pathological variants. Coming to the anatomical variants, in inferior vena cava, superior vena cava, right atrium, right atrium and the vena cava emerge in a mid-esophageal bicaval view which displays long axis views of the vena cava as it enters into the right atrial cavity. First is the Tee-Cce valve. It's a normal structure can be found at the junction of the inferior vena cava and the RA which projects into the RA cavity and can be mistaken for the mass. It's usually thin and mobile but can be thick and rigid. Its typical location allows it to be discerned from pathological structures. A giant Tee-Cce valve should be differentiated from a core triatrium dexter. Cherry network in the RA. Echocardiographically, long mobile filamentous structure having the weep-like motion within the RA cavity. Here in the echocardiography, you can see the cherry network between the RA and the RV. It's a vestigial remains of the right valvula venosus and the septum spurium failed to absorb in the RA. It's a meshwork of the fiber originating about the margin of the Tee-Cce and the Tee-Cce valves and attached in the area of the crista terminalis. Distinction of it from the mass by typical appearance and noting it that it is tethered at its margin although the body is mobile. Right atrial. In right atrial, structures confused for the RA mass are RA wall is trabeculated with the pectineal muscles. Actually, pectineal muscles are distinguished by their perpendicular alignment from the RA wall and the regular spacing. Superior vena cava. When superior vena cava viewed in long axis, there is a prominent ridge at the junction of the SVC and the RA. The crista is called the crista terminalis. Its location adjacent to the RA appendage can be confused with the RA appendage thrombus. Loculated pericardial effusion, sometimes behind the right atrium, and causes the RA wall looks like the intracardiac linear densities. Injection of the agitated saline will help in delineating this RA cavity. Another is the tricuspid annulus. Tricuspid annulus may be accumulate the fat and be prominent when imagined off axis, looks like the mass between the RA and RV. Here in echo image it can be seen there is a mass like structure that is actually tricuspid valve between the RA and RV. Imaging multiplane might help delineate the smooth continuity of these fatty accumulates from with the rest of the cardiac structures. Interatrial septum, there are two normal anatomical variants, lipomatous hypertrophy, which is benign proliferation in which mature adipocyte infiltrate the interatrial septum, more the Kefeld and caudal ends, sparing the fossa ovalis, so causing the dumbbell-like appearance of the interatrial septum and denoted by typical pattern and hyperrefractile nature of the fatty deposits that may cast a prominent acoustic shadow. Here IS is usually 1.5 to 2 cm. Here in the image you can see this dumbbell shape and interatrial septum, fossa ovalis is spared. Interatrial septal aneurysm, prevalence is 2 to 10%, mimic an intracardiac mass, redundancy usually 1.5 cm of the septum with the displacement past the midline of at least 1 cm when imaging off axis. Aneurysmal portion of the septum may protrude into the end out of the plane, giving the appearance of the mobile interatrial mass. Right ventricular and the pulmonary artery. From the right ventricle, several normal structures within the RV and RVOT that can be confused with the mass. Normal trabeculations are quite prominent when RV pressure overload is there. Moderator band is sometimes very prominent and can give the effect like the mass. Catheter and pacemaker leads within the right ventricle appear as small mobile intracardiac echo densities. Actually, catheters are curvilinear structures. When observed in the flat imaging plan, only small portion visualized at any one time, and catheter can form the reverberation and side lobe artifact which can be mistaken for the pathological structures. Coming to the pulmonary artery, main pulmonary artery is typically imagined in the RV inflow outflow view and prominent ultrasound clutter confused with the intraluminal mass. In RV inflow outflow view, pulmonary artery is in the far field where ultrasound beam is spreading. Adjustment of the gain and focus and manipulating the probe, this clutter artifact can be cleaned up. Clutter artifact also prominent in near field when right pulmonary artery image from the mid-esophageal ascending aortic short axis view causing the prominent RPA clutter. Adjusting focus and gain help in the minimizing these and avoid the false interpretation of the RPA thrombus. Another is the pulmonary vein, LA and the LA appendage. Fold of the normal tissue between the left upper pulmonary vein and the left atrial proper is typically linear and of the ridge may appear sometimes bulbous and giving like a Q-tip appearance. It is also called the comedian ridge. Usually is normally present and well visualized in LA appendage view at the 70 degree, and this can sometimes be confused with the left atrial or the left atrial appendage thrombus. When there is a fluid in the in transverse sinus, this pericardial reflection appear continuous with the LA appendage cavity and LA appendage wall, appear as a mass, and when echo dense fibrous material in it confused with the left atrial appendage thrombus. This fibrinous material is common in this LA appendage, and this can sometimes confuse with the thrombus. Pectinate muscle in the LA appendage that may simulate the LA appendage thrombus. Muscle typically emanate perpendicularly from the LA appendage wall and appear multiple in regular space pattern. So, it will be distinguishing the mass from the normal structure. Multiplane approach essential for LA appendage evaluation. LA appendage has often multiple lobes, tissues separating these infoldings confused with the thrombus. Another phenomena, not truly anatomic finding, is a LS spontaneous echo contrast sac or the smoke looks like noted by its echo dense swirling pattern can be confused with the intraarterial mass. Sac in the LA appendage due to the low LA appendage flow, as in certain conditions like mitral stenosis, atrial fibrillation and severe heart failure, sac can be difficult to discern from this thrombus. Multiplane assessment help in distinguishing this condition from the thrombus. Here figure showing echo image of the smoke effect in the LA. Here it is just 4 chamber view, and spontaneous contrast echo is seen with the mitral stenosis. Left ventricle structures simulating intracardiac mass in the left ventricle cavity are one is LV papillary muscles discerned by their location and attachment to the submitral apparatus and similar tissue characterization to that of the myocardium. In mid-esophageal 4-chamber view, base of the interventricular septum may be prominent, suggestive of the intramyocardial mass. Sigmoid septum, normal variant of the aging, the interventricular septum become thickened, is a normal variant for the of the aging process in which remodeling of the LV cavity occur, and it projects the basilar interventricular septum into the LV outflow tract, and which confuse with the mass. Thick fibrous band like highly refractile structure cross the chamber near the LV apex is a false tendon pass between the papillary muscle septum and the free wall of the left ventricular cavity crosses the chamber perpendicularly near the LV apex. Another is the LV apex often foreshortened and looks like filled in the thrombus it confused with the mass. So by certain maneuvers like retroflex the T probe while assessing the left ventricular apex, fully elongate the LV apex, and another view is transgastric view, and the reverse 4-chamber view may also be helpful to distinguish the mass from the normal structure. Coming to the aorta, false positive mass in the intrathoracic aorta results primarily from the linear beam width, side lobe and reverberation ultrasound artifact. Ultrasound artifact due to the near-field clutter may be confused for the thrombus or the atheroma. Aorta can be moved independently of the clutter, and clutter often extend outside the border of the aorta. So this will be distinguishing. Linear artifact may be noted in ascending aorta or the descending aorta. Certain valvular structures like nodule of Arantius and thread-like Lambel's extensions commonly found on the aortic wall in patients older than the 60 years and look like the mass. A large vegetation on the wall can also be confused with the mass. Vegetation usually echodense, highly mobile and attached to the atrial side of the mitral wall and ventricular side of the aortic wall. So its associated finding can be helpful in like a destruction of the wall leaflet or the abscess, which help in distinguishing the vegetation from the other mass. Coming to the pathology, most pathologic cardiac mass represent thrombus, infection and tumor. Cardiac involvement by the malignancy may be primary or the secondary. Metastatic versus the primary ratio is 20 to 30:1. Most secondary involvement of the heart by malignancy is by pericardium. It's 75% incidence. For metastatic, from lung, breast, melanoma and lymphoma followed by the esophageal and the uterine. Melanoma have a predilection for the heart. If intraoperative and preoperative tumor staging differ, the surgical approach may be aborted or altered. So T is very helpful in such type of condition also. In palliative surgery, intra-op improvement in the hemodynamics after tumor resection is vital to operative success. More than 95% of the primary malignant cardiac tumors are sarcoma. Patient may be symptomatic or significant morbidity, pericardial tamponade, arrhythmias or the congestive cardiac failure. Obstruction of the blood flow or the partially dislodgement of the mass can cause embolization. Inferior vena cava, superior vena cava and the right atrium. Commonest is the thrombus. Deep venous thrombi may embolize in the right atrium, appear as a mobile serpiginous irregular mass in the RA. No point of attachment to the RA wall. It may be entrapped in the foramen oval, which can be the potential mechanism for the paradoxical embolization. In situ thrombus formation in the right atrium due to the low arterial blood flow, like a condition of atrial fibrillation or the RA dilatation in cardiomyopathic state, and are homogeneous echo densities adherent to the RA wall with a broad base of the attachment. Right atrial thrombus is along the interatrial septum is unusual. RA thrombi usually have mobile irregularities extending from their surface and prolapse into the RV cavity during the diastole. Here right atrial thrombus protrude through the tricuspid valve. Here it protrudes through the tricuspid valve, and transgastric long axis view of the tricuspid valve showing large right atrial thrombus prolapsing through the tricuspid valve. Right atrial thrombi associated with atrial fibrillation typically form on the right atrial free wall or within the right atrial appendage. RA appendage thrombi best visualized in the mid-esophageal bicaval view. Careful movement of the probe into and out of the esophagus is required to interrogate the entire body of the RA appendage. Here mid-esophageal bicaval view, there is a RA appendage and thrombus in the RA appendage. SVC catheter associated thrombi most commonly form near the inferior vena cava right atrial junction, often on a near the eustachian valve. Superior vena cava catheter, particularly hemodialysis catheter that are stiff and have higher flow, may lead to the endocardial damage that serves as a needles for the mural thrombus formation. Here you can see in the bicaval view, there is a right atrium with a catheter arrow. This is a catheter and right atrium, and this is the mass. In this superior vena cava catheter and right atrial cavity, there is a mass. Thrombi may form around the catheter and become quite large. In right sided panel bicaval view, there is a catheter in the superior vena cava with the thrombus arrow suggestive of it attached to the end of the and left panel showing the short axis of the right atrium demonstrating the catheter with the extensive thrombi. Here in the catheter associated thrombus may involve and extend into the superior vena cava, leading to a partial obstruction. Short axis of the superior vena cava demonstrating the thrombus. Here you can see the thrombus in the superior vena cava short axis view. Thrombus identified by location and associated thrombogenic conditions. It may appear laminated and partially calcified. Right atrial masses may represent primary cardiac tumors. Most common is a myxoma. They typically have well-defined borders and somewhat inhomogeneous tissue characterization. Right atrial myxoma is 20 to 25% of all cardiac myxomas. Like LA tumors, RA myxomas are usually mobile, pedunculated, and if large, may obstruct the tricuspid orifice in the diastole. It emerged from the mid-esophageal forechamber and the bicaval view as well as the transgastric RV inflow view. Tee-Cce to evaluate the tumor attachment, size and mobility as well as the tricuspid valve function. It helps in intraoperative, pre-op and post-op assessment of the mass. Large RA myxoma, large right atrial myxoma, the characteristic shape and attachment of these mass to the interatrial septum in the area of the fossa ovalis make a myxoma very high on the differential diagnosis. Here you can see the large myxoma attached to the interatrial septum. On the right side, the echo image showing the large right atrial myxoma prolapsing into the tricuspid valve. Transesophageal evaluation of the hemodynamic effect of these would be essential. Here this mass will prolapse into the RV from the tricuspid valve. Among the primary malignant cardiac tumors, angiosarcoma is most common. This tumor originates in the right atrial in 80% of the cases and presents as a large mural mass that frequently extends into the pericardium and the vena cava. Secondary involvement of the right atrium by the malignancy by intravascular extension or the extracardiac invasion. Here you can see the mass and the roof of the RA. Secondary involvement of the right atrial by malignancy, it can be due to the intravascular extension or the extracardiac invasion of the RA. Tumor extension along with this inferior vena cava into the RA is a common form of the secondary cardiac involvement in certain malignancies such as the renal cell carcinoma, Wilms tumor, hepatoma and uterine leiomyomatosis tumor extend from the inferior vena cava to the right atrial cavity. It appears as elongated mobile mass protruding into the RA cavity from the IVC. It may be quite large, occupying right atrial cavity, causing the tricuspid valve occlusion. Here echo showing mid-esophageal 4-chamber view demonstrating renal cell carcinoma extending up to the right atrium. Here coronary sinus is visualized and this mass is in the RA just above the tricuspid valve. By advancing the probe in this view, proximal inferior vena cava and the hepatic vein visualized during the resection of the intraoperative TE allows the monitoring of the embolization as well as the positioning of the cannula. Once resection complete, TE will help in residual tumor and the IVC patency. See, this is a tumor, echo image showing the tumor. Here is a IVC, this one is hepatic vein and this one is liver. When probe is advanced from a rightward rotation and from mid-esophageal 4-chamber view, this view can be visualized around at 70-degree forward rotation. Intraop TEE defines cephalic extent of the tumor, extent of the caval occlusion, its relation with the hepatic vein and the mobility of the tumor. Here you can see the stages of this tumor from 1 to 4 and extension of the tumor into the RA. Short axis of the superior vena cava demonstrate an intraluminal mass. The most commonly would be represent the thrombus. However, this mass also appears to be external to the superior vena cava, and the definition of the superior vena cava wall has been obscured. This represents the external infiltration of the superior vena cava by the mediastinal lymph node. This is short axis SVC and here is the mass and external extension. Right ventricular and the pulmonary artery. Relatively uncommon site is the right ventricle, and right ventricular thrombi may occur in the pulmonary hypertension, right ventricular infarction, in the RV contusion. Differential diagnoses are carcinoid heart disease, plaque-like fibrous thickening of the endocardium causes the retraction and the fixation of the tricuspid valve and the pulmonary valve leaflets. TEE findings are either we can see the tricuspid regurgitation or the pulmonary stenosis. Right ventricle heavily tabulated, so detection of the thrombus is challenging. Thrombi in case of the low flow state like or in the right ventricular regional wall muscle abnormalities located in the apex, mid-esophageal 4-chamber and the transgastric RV inflow view confirm the thrombus. Here large apical RV thrombus in the transgastric long axis view. Thrombi in the pulmonary artery exclusively from the emboli from deep venous system, intraoperative TEE to detect residual emboli during the pulmonary embolectomy. Main pulmonary artery visualized using the mid-esophageal RV inflow-outflow view and ascending aorta short axis view. Proximal LPA and the 4 to 6 cm of the RPA visualized from the mid-esophageal ascending aorta short axis and the long axis views. Intracardiac right atrial tumor may partially dislodge spontaneously or during the surgical manipulation and may entrapped in the proximal pulmonary arterial tree, appears as heterogeneous irregular intraluminal mass. So these views are helpful to detect this. Right pulmonary artery thrombus in ascending aorta short axis view. Here ascending aorta short axis view, you can see the thrombus in the right pulmonary artery, and this is ascending aorta long axis view. RPA is in the short axis, and you can see the mass. Pulmonary veins, left atrial and the left atrial appendage. Majority of the mass in the LA are cardiac thrombi. Multiple interrogation required as the LA appendage often demonstrates complex and multi-lobe structures. LA clots appear laminated and have irregular lobulated borders. Thrombi may be mobile or have mobile projections. Rarely large thrombi detached from the LA wall cannot escape the LA cavity and become the free floating. There is a free floating mass in the left atrial cavity, sometimes visualized in the Tee-Cce mid-esophageal 4-chamber view. When atrial stasis due to the atrial fibrillation, mitral stenosis or LV dysfunction etc., Tee-Cce shows spontaneous echo contrast and the thrombus that can be 5 to 15% of the cases this can be detected. Most common cardiac tumor is the myxoma, 75 to 80% in the left atrial. Its rounded or the oval structures may appear fairly smooth. Close inspection reveals the multiple villous grape-like projections. 90% arises from the interatrial septum attached via stalk that arises from or near the fossa ovalis. Only 10% myxomas may be sessile. It may be quite mobile and move towards the mitral valve during the diastole and back to the chamber in the systole. Very large myxoma may interfere with the LV inflow. Intraoperative Tee-Cce helpful to know the presence and the extent of the myxoma, its attachment to the interatrial septum, careful inspection of the remaining atrium and the contralateral atrium as myxoma can be multiple or bilateral. To identify mitral valve dysfunction, both obstruction and regurgitation due to the myxoma, evaluation of the integrity of the mitral valve and the interatrial septum after resection of the myxoma. 3D Tee-Cce allows superior visualization of the size and attachment as well as the mitral involvement. Image showing the thrombus in the left atrial. Other primary cardiac tumors such as the sarcoma, less in the left atrium, secondary to LA involvement by the invasion of the extracardiac extension of the tumor from the breast, lung or the esophagus. Lung carcinoma may invade the left atrial hematogeneously through one of the pulmonary veins. Homogeneous mass filling a pulmonary vein and entering into the LA is mostly bronchogenic carcinoma. Malignant tumors of the left atrial is problematic due to the posterior location and the difficulty for the surgical exposure. Atypical left atrial thrombus on the interatrial septum. Left atrial thrombus normally in the LA appendage or the near the LA appendage, but here it's at the interatrial septum. Left atrial appendage mobile thrombus. Here in 70-degree mid-esophageal 4-chamber view, when forward rotation of the probe at 70-degree, you can very well visualize the LA appendage thrombus. LA myxoma attached to the interatrial septum. Atypical LA myxoma at the LA appendage. Normally myxoma is at interatrial septum, but here near the appendage this myxoma can be seen attached near the mouth of the LA appendage. Lung carcinoma infiltrate into the left atrium. Image showing the infiltrate into the left atrium of a lung carcinoma. Coming to the left ventricle, most common mass in the LV cavity is LV thrombi due to the global LV systolic dysfunction or regional akinesis or dyskinesis of the ventricular apex. Thrombi may be seen in the inferobasilar aneurysm. Apical thrombi appear as mass with increased echogenicity and a clearly delineated border adjacent to the endocardium. Thrombi visualized in the systole and diastole in more than one view. Large pedunculated thrombi is easy to visualize. Small and mural thrombi are difficult to visualize by Tee-Cce. Visualization of the LV apex from 2 and 4 chamber views requires significant retroflexion of the probe. So, LV apex can be completely visualized when T probe is retroflexed. Calcified LV apical thrombus. Here echo image showing the midesophageal 4-chamber view demonstrating a thrombi in the LV apex. Large LV thrombus. Here you can see in the echo image midesophageal 4-chamber view demonstrating a large left ventricular thrombus. Use of transgastric 2-chamber and deep transgastric views, long axis views are also useful for the LV apex. Intraoperative identification of new clot may allow alteration to minimize manipulation or even remove the clot. Several primary tumors involve left ventricle which are intramural. Rhabdomyomas, most common in the pediatric patients, are often multiple, more echodense than the myocardium. It may be intramural or the intracavitary. Fibroma, second common in the left ventricle, usually intramural, involving interventricular septum or the anterior free wall. Size is 3 to 10 cm with the central calcification, usually involve the conduction system, and LV myxomas are normally uncommon. Malignant primary tumors are sarcomas, more common in the RV than the LV. Secondary LV malignancy may occur by direct invasion of the extracardiac mass. Myocardial involvement diagnosed by change in the tissue characterization and akinesis of the myocardium. Tumor infiltration can progress rapidly, and extensive myocardial replacement of the tumor lead to the severe heart failure and the arrhythmias. Last is the aorta and the valves. Most common aortic mass is the atheroma. More occur in the descending aorta and aortic arch, and less common in the ascending aorta. In early atheromatous disease, intimal thickening or more plaque is observed. High or minor plaque is observed. Higher grade atheroma are also present, protrude into the aortic lumen, and plaques are heterogeneous and can have the calcification. Atheromas involve circumferential extent of the aorta. Here echo image showing the dilated aorta with the circumferential involvement of the atheroma. In severe cases, aorta can be involved in entire circumferences. Large atheroma, highly mobile, protruding component that likely represent the thrombus. More extensive thrombi seen in the aneurysmal segment of the thoracic aorta. Aortic plaque more than 4 to 5 mm thickness or with mobile component can emboli during the cardiac surgery. Identification of the external and the location of the extent and the location of the atheroma on intraoperative Tee-Cce prior to aortic manipulation reduces the perioperative stroke risk. Aortic cannulation and cross clamp also should be done under the Tee-Cce guided. Extensive thrombus in the descending thoracic aorta, dilated aorta with extensive thrombus. Primary tumors of the aorta is rare. Secondary, due to the primary lung malignancy, extend to invade the local structures include the thoracic aorta. Tee-Cce used to know the extension. Aortic involvement of the CA lung confused with the intramural hematoma. Common benign tumors of the cardiac wall is papillary fibroelastoma. Are very small, round, mobile, pedunculated, echodense mass, and stroke is usually connected to downstream side of the valves. Aortic valve is most involved, followed by the mitral valve, tricuspid valve, and the pulmonary valves. Although PFE diagnosed incidentally, embolic phenomena has been described. Thank you.